Hello everyone. Today we will discuss about a case scenario which we saw in the rounds. So this case was a 41-year-old male presented with 1 month history of cough and loss of appetite. So this was the presenting complaint. And he was a known case of type 2 diabetes mellitus on OHS, and the recent HbA1c was 9.9%. So we obviously suspected tuberculosis in this case because of more than 2 weeks cough history with loss of appetite. So when we got the chest x-ray, we were suspecting some lesions in the upper zones. But in this case, as we can see, there was ground glass opacity and consolidation changes in the left middle zones. So we commonly suspect radiological changes in the upper lobes, but this case was involving middle zones. But later, when we got his sputum CB-net, it turned out to be MTB positive. So the point here to learn is, whenever we see chest x-ray of tuberculosis individuals, it will depend whether the individual is immunocompetent or immunocompromised. Because in immunocompetent individuals with no medical comorbidities, usually upper lobes will be involved, which we often see, and there will be significant cavitations present in case of immunocompetent individuals, whereas in immunocompromised individuals it will involve middle or lower zones, and there will be less or no cavitations. So our case was a type 2 diabetic individual, which will enlist him into immunocompromised state. That's why he had got the changes in the middle zones. So this difference is very, very important whenever we are dealing with tuberculosis in immunocompetent and immunocompromised individuals. Some of the other commonly associated immunocompromised conditions will be HIV, which we should not miss the association of HIV and tuberculosis, because the management will be little bit different and we have to be careful while initiating ERT because of the risk of iris, which we will discuss in some other videos. So this was about case scenario. Thank you so much.